The broadcast is now starting. All attendees are in listen-only mode.
Thank you, everyone, for joining us today. Today we have Pat here with us, who's going to be presenting on exercise prescription in patients with multiple comorbidities, real-world suggestions. And he will take questions at the end of this seminar. Please type them in the little chat box that you should have on your screen. Enjoy the seminar.
Hi, hello everybody. This is Pat Lara from St. Luke's Heart Health and Rehabilitation in lovely Boise, Idaho. I sort of want to tell you a little bit about our program because I think it'll put into context some of the things that I'm going to speak about. We're a very large cardiac and pulmonary rehabilitation program with a sizable staff. We have 8 clinical exercise physiologists, 3 respiratory therapists, 2 physical therapists, an occupational therapist, 7 nurses, 2 diabetes educators, a physician, and a nurse practitioner. We see about 5,000 patient visits a month. It gives us a unique opportunity to treat a lot of patients that 15 years ago would have been unheard of in my cardiac rehab experience, and to work with a patient with a much higher level of clinical complexity than I would have been comfortable with in the past. And it's allowed us through this multidisciplinary team to hopefully optimize these patients and work around some of the comorbidities that we frequently see, as well as some of the ones that previously would have excluded patients from participation in a program such as ours. So we're familiar with drugs and drug prescriptions that physicians write. I don't think we have quite caught up as exercise physiologists to the level of sophistication of the physicians, and I think we have an opportunity to truly start thinking about exercise prescription in terms like a physician would for medication. So I'll use treatment of hypertension because that's something that a lot of people can be comfortable with. We know that there's multiple kinds of drugs that physicians can prescribe to treat hypertension. There's diuretics, there's beta blockers, ACE inhibitors, angiotensin receptor blockers. There's all sorts of different kinds of drugs that can be prescribed individually or in combination. There's dosage, there's the frequency that they're given, what route, and like all drugs that a physician prescribes, and like all exercise that EPs prescribe, there's a cost-benefit analysis that has to be done with that prescription to get the desired effect versus the side effect. If you get prescribed the maximum dose of 2 or 3 antihypertensives, you would have no blood pressure and there would be some dramatic side effects that would be avoided. The same goes with an exercise prescription. If you prescribe too much or too hard, you're going to get some undesired side effects as opposed to the desired effects that go along with the exercise. So frequently when a physician starts somebody on an antihypertensive regime, they'll start with one medication, they'll up-titrate and potentially add a second or even a third medication until they get the dose response that they want with a minimum of the side effects that they want. That's how we think about exercise prescription in these complicated patients, is to start with 1 or 2 interventions at a relatively low dose, up-titrate to the desired effect, trying to avoid the unwanted side effects. The exercise prescription, we're all familiar with doing that. What I think, if you get nothing else out of this talk, it's that the exercise prescription, just like treatment of hypertension, is a living, breathing thing that has to be adjusted frequently to get it dialed in, and has to be readjusted periodically to get the effect that is wanted versus the unwanted side effects. So everybody on the call, I'm sure, is familiar with this slide. You know, we all know if this was a drug that could be given in a pill, that everybody would be taking it and they wouldn't really need us. Unfortunately, patients are uncomfortable or unwilling to deal with the side effects of exercise because they frequently have had a bad experience with these side effects in the back, the most common being late onset muscle soreness. They get fatigued. There can be syncopal episodes, particularly in these complicated patients with multiple comorbidities. They can become hypoglycemic. They can have angina or claudication pain. They can get short of breath, and frequently they'll get overuse injuries that are commonly seen because the dose is started off too high and there's not accommodation made for pre-existing conditions. Arthritis is a big issue with these elderly, complicated patients, and that can get riled up with too much dose initially, and patients can just get sick of it. So we're going to kind of go through some of the techniques that we use here to try and avoid some of that, and hopefully be able to work through some of those. I have a list of comorbid conditions complicating an exercise prescription. The biggest takeaway from this slide is that in order to be able to prescribe appropriately, you have to have an incredibly thorough history. That's one of the failings that I see in a lot of programs, is the level of detail that people will go into on the medical history. You can't make accommodations for patients if you don't have a good history. I review program certification for AACVPR, so I get to look at a lot of program certification applications that include care plans, and I'm constantly amazed at the lack of information on many of these care plans in a cardiac rehabilitation or a pulmonary rehabilitation setting. These are sick patients, and it's very difficult to tell from reading these care plans what all's wrong with this patient to be able to know if the exercise prescription is being done appropriately. Frequently, they'll have a pretty good cardiac history if they're in for cardiac rehab, or they'll have, you know, good pulmonary history for pulmonary, but as far as all of these other things on there, it's sometimes hard to tell. And when you look at the AACVPR outcomes tool, there's a section in there that'll show you what comorbidities are seen frequently and what percentage of the patients, and I'm relatively shocked that, you know, if you look at the national data from the registry, only 10 or 15% of the patients in the cardiac rehab program are listed as having type 2 diabetes. Well, we know that the national incidence for diabetes is 10%, so why wouldn't we see a disproportionately high number? We see more like 25% here. My guess is they know that, but are they taking that into account with their exercise prescription? Some of these comorbidities are on the relative or absolute contraindications to exercise, and many years ago, if I had a patient come into the program with severe aortic stenosis and I got the referral, I'd be like, nope, can't take them. Patients get aortic stenosis, we can't exercise them. Well, we've learned through trial and error that yes, you can, you just have to be careful. Pulmonary hypertension is a similar diagnosis. Patient has severe pulmonary hypertension, yep, can't do it. They're not going to be able to tolerate it. Well, yeah, they can. It's just going to be very, very low level exercise, and it may be able to be worked around. So what I want to dive into, and what we're going to spend the majority of our time on today, are looking at these case studies. And I want to kind of go through these case studies one at a time and ask some questions at the end of the last one to try and see if we've gotten this. This is how we do our handoffs. It's an S-bar. A lot of you guys probably understand that The S is for situation. This is a 74-year-old who was referred to cardiac rehab for a type 2 non-STEMI. Patient was in the hospital with a diagnosis of shock, metabolic encephalopathy, secondary to narcotics, and an acute hypercarbic respiratory failure. And then went into multi-system organ failure, had an anoxic injury, and because of all of this, had a troponin bump, that's the type 2 non-STEMI, and took a hit to their kidneys, liver, rhabdomyolysis, and a UTI. And all of this started when the patient suffered a fractured arm due to a ground level fall. Got put on Norco, got a little happy with the Norco, and ended up coming into the hospital. So B, for background, this is a heart failure patient with preserved ejection fraction. They've got carotid artery stenosis. There's the kidney injury, hypertension, GERD, mitral valve disorder, and a lot of the stuff that we would see, but we might not necessarily dig into when we were writing the exercise program. You'll see a Roux-en-Y on there, arthritis, fibromyalgia, a lot of the stuff, again, that we see frequently. On intake, they did 965 feet on a 6-minute walk, had to stop. SATs dropped, but there's a question about the signal quality, at least in this particular patient. But we do know that they have a history of COPD, and the follow-up on this is we're going to have to check them to see if they're going to need supplemental oxygen. They got short of breath. And then you see what the initial exercise prescription was. So I want to go through this case study again after we've gone through the stuff that we're going to need to pay particular attention to. So when we get a patient in and we're looking at this history and the evaluation, we sort of prioritize the things that are going to get us in trouble. So pulmonary or hemodynamic instability, those are the ones that are going to have you in a code situation, and you're going to have to stay in front of that. Signs and symptoms would include inotropic incompetence, dyspnea, dizziness. You see all that on there. A lot of it is subjective and some of it's objective. You know, the patient may have rhythm issues. More frequently, we won't see rhythm issues. We'll see the patient start to look bad, and the rhythm issues may or may not follow. There's also an underlying cause for most of those instabilities. Most frequently, when you get into these high-risk patients, you're in a mismatch situation. You've got a supply and a demand mismatch. You've got aortic stenosis, you've got excessive demand peripherally, and the central system is unable to supply that demand because the valve's tight and there's not enough blood getting into the system, so the patient gets lightheaded and passes out, or that you get a rhythm problem. Same sort of problem with pulmonary hypertension, whether it's primary or secondary pulmonary hypertension, doesn't really matter. All you know is that the patient needs more oxygenated blood and there's not enough perfusion to the lungs, so there's not enough oxygenated blood getting into it, and the patient gets some sort of peripheral fatigue, shortness of breath, and you end up with a problem. You see the same thing with congestive heart failure, both with reduced ejection fraction or preserved ejection fraction. You're not getting enough blood out because the squeeze is not strong enough, or because the stroke volume is low because the patient's got a diastolic dysfunction. Either way, they're not getting enough blood, they're getting lightheaded, they're getting peripheral fatigue, you end up with a problem. Angina, similar situation. Now the heart's not getting what it needs. Anemia is one we see that comes up relatively frequently, that gets missed unless you're paying attention. Patient short of breath, patient's becoming unusually fatigued. You can't find an underlying cause for it, but their H&H is 6 and 20. Well, yeah, there's just not enough hemoglobin running around to carry the oxygen, so you've got this supply and demand mismatch. Then you have the secondary levels, the ones that may not necessarily end up in a code situation, but you better be paying attention to. That's patients with hyper or hypoglycemia. A comment here about type 1 versus type 2. The vast majority of the patients we see are the type 2 diabetics. We don't get too excited about patients who are type 2, who appear to be well controlled. They're on no meds or they're just on metformin. The chances that you're going to get a hypoglycemic event in a type 2 on metformin are exceedingly low. However, once they get on insulins or some of the other oral agents, you do have to be constantly monitoring those sugars. You are adding another drug to treat their diabetes with the exercise, and frequently, more frequently than not, the medications that the patient's taking to treat their diabetes need to be adjusted downward once we get them on an exercise program and they get to where they're doing a significant amount of activity. A quick word about type 1s. These patients are much more challenging to manage. They frequently are on pumps, and most of the time us getting involved in that is just gonna frustrate that. They need to deal with their endocrinologist on that. The only thing we really pay attention to are the patients who come in exceedingly high that are type 1 diabetics. Patients that are type 1s with elevated blood sugars beginning an exercise session can have a paradoxical effect to the activity. The catecholamine release associated with the activity can cause their blood sugar to go up rather than down, and so you have to hold exercise in these patients when they get up in that 300 or 350 range until you can get clarification from their endocrinologist. Neuromuscular and orthopedic concerns and fall risk, these sort of fall into the same category. Those patients with neuropathies or gait abnormalities, macular degeneration, balance problems, fall history, all of these guys, while they may not necessarily end up in a full-blown code, you have to be aware that a fall for these frail elderly patients could potentially have an incredibly high level of morbidity associated with it, if not mortality. I think we've all seen that. One of our patients will fall, end up in the hospital, and never get out because they don't have any reserves to be able to fight that off. So it's important to do a thorough fall risk evaluation, and not just like a get up and go test or a time sit stand or a 4-point balance test or something like that. I'm talking about getting into it with them about what is their fall history. Do they have other things like the neuropathy or like macular degeneration that might make them more prone to falls, and then make accommodation for that. Put them on some balance specific exercise as part of your prescription to sort of attenuate that fall risk so you can avoid that. And then the stuff that we spend a lot of time doing, is just aggravation of prior conditions. Folks with bad hips, bad backs, bad shoulders. Frequently we'll get patients in rehab who were going in for a hip replacement, but as part of their pre-op workup, it was discovered that they needed a bypass. And so now we've got this patient who's not going to be able to get that hip for 3 or 4 months if they had bypass, or a year if they had a stent because they're on Plavix. So now we were having to work around that bum hip. That's where we lean on our physical therapist to help us work around some of those problems and potentially make them a little better surgical candidates when the time comes. Other things that come up, and again, these are not necessarily life-threatening, but they do prevent the implementation of a good balanced exercise prescription. Morbidly obese patients tend to have a lot of other problems, not just their heart disease or not just their orthopedic problems. They've got just the physical pannus that prevents them from doing a lot of exercise. They weigh so much that any type of activity is just a strain, and they don't want to do anything because it's just so much work. Peripheral vascular disease, we see a fair few patients with that. That limits any weight-bearing activity they can do. Claudication protocols for conditioning of those folks has better outcomes than surgical interventions. Unfortunately, it's not reimbursed, but we frequently will put patients on claudication protocols, and they can get good response from that if they're willing to suffer to do it. Low back pain is another thing we see in a large percentage of patients that you sort of have to work around. It's not really inside the scope of our program to treat that low back pain. However, with general conditioning, weight loss, increased abdominal strength, and better hamstring flexibility, most of them get a little bit better. The point is not to aggravate it when they're here. Osteoporosis, aneurysms is something we watch, but again, you have to be doing a relatively thorough history to pick up on that stuff. So let's go back and look at that case study again. I sort of color-coded it for everybody when I went through here and said, okay, what is it, red, yellow, and green? What is it that jumps out at me that I'm going to want to pay attention to writing this program? The red stuff are some of those high-level concerns, the yellow, the intermediate concerns, and the green, the things that will get in the way that might not necessarily stop them from exercising, but could be a complication. So the fact that the patient desatted when they walked makes me think that that COPD diagnosis may be accurate. I'd be asking the physician to see if we could get a pulmonary function test and also monitoring their oxygen sats in order to be able to adequately exercise that patient. Patients are hesitant to get on oxygen initially. However, we've had good luck, at least in an exercise setting, by letting them know that, hey, we can work you harder if we put you on oxygen, and it's not that you're ever going to get off of it, but you may be able to get a little more efficient and do more. Typically, when they agree to get on it for exercise, they'll go ahead and say, hey, I feel better, I'm able to do more, I'm not as short of breath, and lo and behold, we can train them up a little harder. The yellow, these would be the things that would need to be followed up either by our physician, nurse practitioner. The acute kidney injury could cause some problems in a couple of different ways. It could cause a problem if we're worried about electrolyte imbalances. It could cause a problem if the patient was diabetic, if they've got an acute kidney injury. Insulin's cleared in the kidneys, and if it's not being cleared as well because the kidneys aren't working, more of it could be circulating and the patient's sugars could start to drop, and we'd have to keep an eye on that. Rhabdo is its own kind of thing, and usually it's transient, but there can be quite a bit of localized muscular damage from that could make it difficult to train these patients. Heart failure with preserved EF and the carotid artery stenosis, definitely something that could cause us some issues, but would hopefully show up in a non-emergent way. That mitral valve disorder, those typically don't cause us much trouble here unless they're really, really bad. But I'd want to be mindful of that. Patient did have an arm fracture, easy enough to work around. The fibromyalgia, again, easy enough to work around, but I would want to be careful when I was working with that patient. So this is second case study. I've got the next several case studies color-coded for us as we go through here. This is a lady that was referred post-transcatheter aortic valve replacement. These patients typically are the ones that the surgeons don't want to do open, so they have a lot of stuff going on with them. We see that this patient was being worked up for gastric bypass, so we can assume that this is a large person, and they've got this bad aortic stenosis that was picked up. The balloon valvuloplasty prior to the TAVR frequently has neurological consequences, so we'd want to be paying attention for that. Patient went into a complete block during surgery and had a pacer. Nothing that exciting there, happens from time to time, but we'd have them on tele and know what was going on. This patient was sent over here by her bariatric surgeon and said, yeah, well, you finish with cardiac rehab and we'll talk about doing the gastric bypass. Normal ejection fraction, marginally controlled diabetes, and a pretty high BMI. So here's everything that they're on. We have heart failure, diabetes, on insulin, COPD, macrocytic anemia, respiratory failure, and morbid obesity, all those things that we sort of talked about previously, we would have to be paying attention to while they're here. One word about the chronic respiratory failure. The one that people tend to attach onto is a hypercarbic respiratory failure. That's when patients essentially quit breathing, and you have to be concerned, at least in an acute care setting, about titrating their oxygen up too much, because then the respiratory drive lowers and they quit breathing because they've got this hypercarbic situation going on. That doesn't apply in an outpatient setting. If the patient's a CO2 retainer, you don't really have to worry about up titrating their oxygen. That's, you know, the demand from exercise and the rest of the regulatory mechanisms. The patient's not going to stop breathing in the middle of exercise, but I think people have been taught that so often that they're like, oh no, he's a CO2 retainer. We have to be careful about their oxygen. You have to be careful about their oxygen while they're sleeping, but not necessarily in an exercise setting. So here's our assessment of this patient. Lots of orthopedic stuff going on. A 35.6 second get up and go is pretty long. If you're not doing that particular test as a point of reference, less than 10 seconds is considered low fall risk. 10 to 15 is moderate fall risk, and above 15 is considered high fall risk. It's going to need some assistance with transfers. Only did 285 feet on a 6-minute walk. Again, probably a function of the COPD as well as a function of their size. Patient desatted rather badly. Could be from COPD, or it could just be the patient is so heavy that fat mass is impeding ventilation. Obesity-induced hypoventilation syndrome is relatively common and unrecognized. These patients just get so big they can't fill their lungs up. It's just too heavy and too much work, and there's fat in the way. So that's going to be an issue, trying to do much with this person, particularly trying to get them tuned up for a gastric bypass. So we decided to just see what we could do with this person. I'm not going to spend a lot of time on these exercise prescriptions right now. The point being, somebody with a BMI of 62 who can only do 285 feet on a 6-minute walk is not going to be doing a whole lot of walking in our situation. They just wouldn't be able to do very much of it. The demand is too much to move that mass around, and the patient's going to get symptomatic, and we're more than likely going to end up with some other kind of an injury. So we'd probably have them on some sort of recumbent modalities, in this case new step and rowing using upper bodies only, sort of see how they do with that, and then increase. The patients of these size, even on a new step or a recumbent bike, recumbent elliptical, the pannus from the obesity is just so large that they can't move their legs, and it's unfortunate, but the reality of trying to work with these guys. So I'm going to pause there for just a minute because I've been rambling on for half an hour. I want to open it up for questions. Not hearing any, I'll just continue to ramble. So this is another patient, younger man, 52, had a non-STEMI and myocarditis, secondary to a virus. Had no obstructive coronary disease, so he had a viral-induced cardiomyopathy, which, again, we see not infrequently, half a dozen times a year, maybe 10 times a year. And unfortunately, his presentation is similar to a lot of the ones that we see. He's now got a reduced ejection fraction, 30 to 35%. So that may or may not come back over the next 3 months. Treatment for that is medication and exercise, so he'll be followed up with his cardiologist after 3 months to see if that damage was temporary or permanent. Unfortunately, with that reduced ejection fraction comes the risk for sudden cardiac death from dysrhythmia. Patient did have a defibrillator put in, which makes us feel a little bit better about exercising them. Unfortunately, the patient is prone to dysrhythmias. Patient had an ICD storm. As we see there, he got 13 shocks and was eventually brought into the emergency room, had more shocks in the emergency room. They eventually turned his defibrillator off and did an interrogation and found out that all the shocks had been delivered appropriately. He did end up with some thrombophlebitis and some other issues going on with that. A word about AICDs. They really make us feel a whole lot better in these patients with low ejection fractions, patients with previous out-of-hospital arrest, or demonstrated sustained ventricular dysrhythmias. However, when the patients are defibrillated with these devices, it's pretty damned uncomfortable. And after a while, if this continues to go on, it would be likely that this person would just say, no, I'm not doing it. There was an article came out about a year ago, I guess, that said after about 7 defibrillations, these patients develop a post-traumatic stress disorder. They're just walking around on pins and needles waiting for the device to go off. And in this case, this guy, it was extremely tentative. So worried. That was the primary reason that he even agreed to come in. He'd been relatively active previously, but just was fearful about doing anything because it was going to elicit shocks from his defibrillator, and needed to know what he could and couldn't do, and he wanted to do it in a controlled setting. So he was being way more cautious than we would, and based on his history, looking at this, we probably would have been relatively aggressive with his exercise prescription, but we started him really, really low on some pretty simple modalities because we needed to desensitize him slowly. So the exercise prescription is not always based on the clinical picture of the patients unless you consider the psychosocial complications part of that clinical picture. You have to put it into context. Patients frequently don't have much of an exercise history, and a lot of their trepidation to starting a program has to do with a lack of experience, or some of our older ladies have no exercise history, and so it's not anything that they're real comfortable with. Or on the other hand, you have the guy who was a Marine 20 years ago and thinks he can still do what he could, when he was 22. So let's go into the next case study. 58-year-old woman had a non-STEMI, had a chronically occluded right coronary, and was not a surgical candidate. And so she was sent over here for medical management and then potentially going in for CABG. These are the patients that make me relatively nervous, that these medically managed patients that either are bad surgical candidates and they want tuned up for prehab, or they want to be medically managed and failed before the risk benefit of doing the surgery is now worth it. So we go through there and we see EF is relatively normal, but then we get into the pertinent medical history. This is a type 1 diabetic with a right below the knee amputation, and the usual cast of characters that you would see for type 1 diabetic of this age with poor control. Not just the amputation, retinopathy, neuropathy. I have neuropathy down there twice. Oh, that's supposed to, nephropathy. So bad kidneys, bad nerves, lost her foot, and peripheral vascular disease. So when we worked her up, she did have a significant fall history, and she reported that her prosthetic is too big and that she's trying to accommodate that with extra socks. So we have several problems going on there. We probably wouldn't put this person on a walking program for a couple of reasons. That prosthetic not fitting well, patient's a fall risk, but we'd also worry about some sort of injury to the stump in a diabetic patient would more than likely end up with a chronic wound situation that would limit our ability to continue to exercise her. This is a very high fall risk patient, not just because of the amputation, the retinopathy and the neuropathy all make her high risk. She can't see, she can't feel her feet, and she's got a fall history. So that's one of the things that would jump out at me. However, that would not preclude us from doing some decent recumbent activity to try and get her tuned up relatively well as we go through here. So case study number 5. What I'm going to do here is I'm going to go through the first. I'm just going to read through this, and I kind of want the folks on the call to sort of chime in the things that jump out and what they think they would do with a patient like this, as far as what would they be particularly careful of, what would they need more information on, what would get them asking questions and working with this. So this is a 72-year-old patient with known coronary disease, had a CABG recently, showed up in the ED. These are all actual patients, by the way, that have come through our program in the last month. Came into the ED in December, had a stress test, and sure enough, one of the vein grafts had gone down. They stented the OM and put 2 stents in the RCA. They did have some pancytopenia that's now better, but they do have a left foot diabetic ulcer. They have marginal anemia. They've had non-sustained VTAC, hypertension, peripheral neuropathy, macular degeneration, not bad control on their diabetes, and they had previous aortic stenosis, but when they did that bypass last May, they also replaced that aortic valve. We did a staged recumbent bike test on this patient because of that foot ulcer, and we didn't want to get it riled up. Patients in a walking boot because of the wound. Did okay, 4 mets. Stopped because the patient reached an RPE of 6. That's our protocol here for submax tests. Not a bad get up and go. And GAD and PHQ, those are depression and anxiety scores, and so forth and on. So I'm going to open it up now, and I want you guys to sort of chime in. We're going to go through your thoughts on this particular patient. So the first question I have is how many falls in the past? So that's a good question. If it's not on there, I would assume that they did not have any recent falls, but that's also good. Can you address CHF with reduced EF and blood pressure while exercising? That specifically drop in blood pressure while exercising. That's one I'll hit at the end. One of the questions is, how would the effect of the updated ACSM pre-participation approach impact on the way you treat these patients opposed to their current low, moderate, or high-risk stratification? We do risk stratify according to those criteria. The low, moderate, and high risk affect the amount that we progress the patients, how quickly, how fast they go on to weights. We use a lot of MIT and HIT training for cardio here. Even our high-risk patients are patients with an ejection fraction of 15 or 20% eventually get on HIT training. But how fast we put them on there is affected by their risk stratification. Concerning the boot recumbent bike as a mode of exercise, those boots are put on there to avoid direct stress, so they protect that diabetic ulceration. So as long as they're in that boot, they would have relatively good protection. However, standing up, doing long repetitive things, you can't always depend on that that protection until that one's a little better healed. Trying to find a couple more of these questions here. They're coming in. What was the duration of the staged recumbent bike test before the RPE of 6 was stopped? Again, that's another good question. We do 2-minute stages with a branching protocol designed to be no longer than 12 minutes. So I don't know. Based on the format, my guess is it was a 6 or 7-minute test. We have the way we do our submax test. RP of 6, patient request to stop, 90% of heart rate reserve are all grounds to terminate the test. There's another question on here about the get up and go test. Low, less than 10 seconds, 10 to 15, moderate, and so on. I've used a cutoff of less than 8.5 is high risk. Can you elaborate a bit more on your grouping? That's what we use, the less than 10, 10 to 15, and greater than 15 for low, moderate, and high. Anybody that is longer than 10 seconds, that automatically triggers a balance and a fall evaluation by one of the physical therapists or one of the occupational therapists. So we do a risk stratification for fall as well as for cardiac event. That grouping was based on feedback from our therapy team, and so I don't exactly know what that reference is. I can look at that and get that back to you later. But we do the pre-post evaluation by that team. They get put on a fall program, and then we test after we have outstanding results from those balance programs. Even though anybody on our team, whether it's an EP, RT, PT, that does that intake that feels the patient's a fall risk, even if it's not based on the get up and go or the fall history, they just don't like the way they look, they can always trigger that referral. So a lot of these things are guidelines more than hard and fast rules. So just because the patient had a 9-second get up and go and no fall history, if they're scaring you while you see them maneuvering in the gym, you need to consider them a fall risk. Here's another question on this particular patient. Would I use an upper body ergometer once sternotomy is healed? That would depend on the patient's goals. Patient stated goals sort of drive what we do. What is it that they're trying to get back to? This particular patient, we don't have that in here. I can tell you from our standpoint, we're trying to get them back to doing everything that were pre-event at a minimum. Most of them end up doing better. More often, we try and get some sort of a real-world example of what is it that they cannot do now functionally that they want to be able to do. One of the things that we hear in our part of the world is, I've got an elk hunt I pulled an elk tag this fall and I want to go elk hunting. Well, that's a relatively high physically demanding activity that we've got to get them trained up for. We've had wildland firefighters who have to pass a pack test. Very specific, we know what we're training them for. We had a dairy farmer in here last month who said, I need to be able to carry 2 bales of hay for 100 yards. Okay, fine. He had a sternotomy. That was probably going to be a problem, but we had him walk laps on the track, 100 yards intervals with dumbbells. As his rehab went along, by the time he got done, he was carrying 2 55-pound dumbbells, for 4 laps around the track. He was able to do what he wanted to be able to do by the time he got done. So we try and be as specific as we can about what the goals are. So I'm looking at this next question. All the tests done the same day. Any practicing of tests prior to the actual test? No, if you're talking about that, the learning curve associated with these tests, the really low functional class of patients, we just do a 6-minute walk test on. That's got good validity without that test retest. We don't put people on the treadmill unless they're comfortable with the treadmill. So yes, that could be an issue. We're migrating now to just doing a full-blown stress test on everybody, pre-programmed, so that we can get better data for our exercise prescription. But it's not implemented yet because it's a big time suck, and we're busy otherwise. I'm looking at our time, and I want to be respectful of everybody's time, but I'm going to jump into some random suggestions, and then I'm going to go back and answer some of these questions, so please keep coming through with this. There's an interesting tool called the Charlson's Comorbidity Index. It'll sort of give you an objective measure looking at all the patients' comorbidities. However, when you see these complex patients, you sort of know them when you see them. We've all seen the 52-year-old patient that looks horrible, and then you see the 90-year-old patient that looks great. Don't use age so much as all these other things, but the bottom line is you can start off more slowly than you think, just like the physician is going to start with a low dose of an antihypertensive, because you don't want to get yourself in trouble by doing too much. We generally, if somebody hasn't been active, will be very gentle for the first 3 to 4 weeks, so that connective tissue toughens up, so we can avoid some of those overuse injuries. We get that a lot. Hey, that's all you want me to do? And after the first visit or two, we really don't get that. By the end of the program, like I said, 70% of our patients are on high-intensity interval training by the time they graduate. They'll get where they need to be, but let's start off slowly and increase the dose under careful control. Listen to your patient's goals. I touched on that earlier. We as EPs, we have our goals for the patients, but more often than not, we need to listen to the patient and make sure that their goals are our goals. That patient that wants to go on the elk hunt, we need to listen to that and try and train them specifically. Bring your pack in. Let's put you on the treadmill, walk you on a hill, whatever it takes to get them where they want to be by the end of the program. On the other hand, when the patient comes in and says, wow, I went to the grocery store for the first time in 10 years, I'm so happy, you may just say, good enough, we're ready to back off, because you got the dose response you wanted. You don't need to keep adjusting the dose up. Medically complicated patients most commonly have poor exercise history, or they wouldn't be that medically complicated, and they're intimidated by the setting, and starting off slowly makes their lives a little easier. This is the thing that I work with on our younger EPs, because we tend to want to keep increasing the dose, right? We want more, heavier, faster, longer. At some point, the patient's able to do everything that they want to be able to do, and that cost-benefit analysis that you're always trying to balance. Why are they doing more? Do you really need to get them where they can run 5 miles when they were happy being able to go to the grocery store for the first time in 10 years? At some point, they're going to get to I'm able to do everything I want to be able to do, and you stop adjusting the meds. You don't need to keep increasing it. Now the program's going to need to get mixed up. Maybe you say, okay, well you've been doing that stuff for a while. Let's go over here and try the rower, or let's try the ski erg, or let's try some new equipment, just to keep it mixed up. But you don't necessarily need to continue to increase the time or the intensity or the amount of weights that they're doing. To do what they want to be able to do. You're putting them at risk for some of those overuse and side effects, those unwanted side effects that they're going to get by continuing to increase that dose. The other thing that I think we don't do enough with in these debilitated patients is strength training. I think, you know, we say, okay, we're gonna do cardio and that's going to solve all of our problems. A lot of these incredibly debilitated patients, their functional limitations are from a lack of strength, not from a lack of conditioning. And we don't do strength training in our settings, frankly, because it takes more time to teach them to do it. It takes more hands-on to get them good at it, and it's harder for them to get comfortable with it. However, if you're having issues with functional limitations in a patient, I would strongly encourage you to consider it, particularly in the frail elderly and the fall risk patients. Again, their most common problems are that lack of strength. The other thing that we as EPs tend to do is we want them to get that 150 minutes of cardio a week. We want them to make sure that they're doing their strength training 2 or 3 times a week and their flexibility. Some of these really, really sick patients, it's just not going to happen. And you have to get your head wrapped around. If you can get them doing 15 minutes 3 or 4 days a week, that's going to have to be good enough, because continue to push them is going to set them up to fail and not feel good about what's going on. You just have to remember that there's a dose response, and you're not always able to get them to what is generally considered a therapeutic dose. So I'm going to start diving into some of these questions because we've only got a few minutes left here. And there's a fair few questions, so give me a minute to kind of sort through and see. Can you give us a quick outline of your HIT protocol? So we based our HIT protocol on those studies that came out of, I think it was Sweden, the 4-2 sort of a setup. Our low-risk patients will start on HIT training after their first 3 visits, and it is trying to think exactly how it is. Again, it's based on those studies. I think it's 80 to 95% of their heart rate reserve. We start them at 1 minute with 3 minutes rest, and then we eventually flip those times to where they're doing 4 minutes on and 2 minutes off. Our moderate risk patients, we start on MIT training, which has them at 60 to 80% of their heart rate reserve. Same sort of setup, and when we get their time flipped to that 4-2, we'll move them to a formal HIT program. And then our high-risk patients, we keep a little longer, 6 to 12 visits, and then they'll flip over to MIT and then eventually over into HIT if they can tolerate it. They have to be able to tolerate it physically, but then they also have to be able to, you know, they won't have to want to do it. And again, if they don't, that's why only about 70% of them, it's not going to, that's not their goal, but a lot of them, it's the fastest way to get the results. Here's a question: which stress test protocols are you using? There was a study published, I think it was a Canadian study, and the name of those treadmill protocols are Fouts and Terry. I can send out the link to that study that demonstrates the safety and efficacy of those treadmill tests in our setting. They're ramped treadmill test. Again, 7 stages, 2 minutes. Will you touch on cancer disease with patients? That's really my coworker Ben's area of expertise. He does the most of the work with the cancer patients. I can tell you in my experience with cancer patients, if they're undergoing active treatment, I don't get too excited about doing much with them. This is the case where anything is better than nothing. There's tremendously good research on patients undergoing active treatment that it attenuates a lot of the bad side effects that you see with chemo and radiation, but active treatment is not the time to be trying to progress them aggressively because they've got too much other stuff going on and they don't feel good. However, you are minimizing the deconditioning that would happen in the typical cancer patient because they typically don't do anything. So as soon as the active treatment's over, they tend to respond a little faster and recover a little faster because they were doing something during their active treatment. I tend to look at these guys more as somebody with a bad immunocompromise. A lot of the cancer treatments we do really knock out their immune system in one way or the other. They've frequently lost a lot of weight and done some other stuff, so nutrition is important, but they're not hungry. Again, I think in my experience, strength training with these patients is typically better tolerated and gets better long-term results throughout the course of their cancer treatment and recovery. And I would preferentially prescribe resistance training over. I'd just do some general light cardio and then really, just try and maintain muscle mass through their treatment. And I'm looking at Ben because he's in the room with me and he's sort of nodding. I think that's sort of the general consensus with those guys. Here's a question. What is the protocol for titrating O2 when a COPD patient is a known CO2 retainer? I've always been taught not to titrate up. So again, you don't titrate up that patient for their sleeping oxygen prescription, but for purposes of their exercise prescription, it's exactly the same as anybody else. We titrate oxygen to maintain sats at 90% or higher, even if we have to go to 15 liters on a non-rebreather. We will have known CO2 retainers with a history of hypercarbic arrest on 15 liters of non-rebreather. They will not stop breathing. Believe me, the neurohormonal mechanisms associated with exercise override that process, and we need to maintain their sats to sort of prevent progression of the disease and other end organ damage to be able to train them. Let's see here. A couple of other questions. We're very close to being out of time. How do you set your target heart rates if you don't have stress tests? Where do you start them so you can titrate up from there? That's if we had a max stress test on everybody, that would be beautiful, and we'd be able to geek out as exercise physiologists. The reality is, most of the time we're not going to. We tend to not get too caught up in our exercise prescriptions, even though we do use heart rate reserve, as I indicated earlier. To us, RPE is a trump for that. You have a patient who's got a good exercise history, they know their body well, they're going to be able to tell you how hard they're working. A lot of the medications are new to the patients, and it's a trial and error process with the exercise prescription and heart rate, while used for athletes is not always effective here. There's a follow-up question from that same individual that says, heart rate reserve based on 220 minus your age. Yeah, typically it's 220 minus your age or 205 minus half your age. Depends on the EP. Our protocol allows for both of those. But again, if the patient's symptom limited, then we're unable to do some of that. Does the fact that they are on 4 medications or more increased fall risk after they get up and go affect it? Yeah, I've seen some of those studies that look at polypharmacy and fall risk, and yes, definitely in a hospital setting, polypharmacy is an issue. The average patient that walks in our door is on 13 different medications, so it's a little difficult to use that as a metric. So pretty much everybody that walks in the door would be considered high risk. I'm going to do one more question because we're over time, because this is one I get a lot. Can you address CHF with reduced ejection fraction and blood pressure? So I touched on that just briefly at the beginning. That's that inotropic incompetence. So you exercise that patient, you increase them, you should see an increase in systolic blood pressure of 10 to 15 millimeters of mercury for every MET over resting that you get. But you put this guy on the bike, you put him at 3 METs, his resting blood pressure coming in was 120 and now he's 100. That's bad, and whenever we see that, that shows that mismatch, and we know if we continue to progress that patient, we're going to get in trouble. We've found being recumbent modalities and not doing multi-joint that you decrease the demand systemically, so you're able to get a little bit. Again, this is a patient that I would probably preferentially prescribe resistance training, at least initially, along with recumbent modalities until you got some peripheral adaptation and potentially efficiencies, and they might be able to tolerate more. But if they have a lousy EF, they may never be able to do more than 3 or 4 minutes worth of activity. If this guy is one of those that wants to go do that elk hunt, then that's a different conversation about what's a new normal that we have to have with them. So we're actually over now. So if you can send additional questions to cepa.cont.ed@gmail.com. Again, that's cepa.cont.ed@gmail.com. And with that, I'm going to sign off since we're over time and turn it back over to Ben or Tim.